Hello, my name is Tony Suladolnik, and I am an undergraduate student in the University of Illinois at Chicago Kinesiology Department. The purpose of this research project is to raise awareness of mental health within the performing arts dance community, show the relationship between dancers' competitive environment, injuries, and how the healthcare system influences a performing artist's state of mind, and to give recommendations to help performing artists get mental health assistance. The biopsychosocial model of a dancer is unique and complicated. Dancers use their body as their tool and product. They can dance between 24 and 38 hours a week. Before becoming a professional dancer, dancers go through pre-professional programs. Pre-professional dancers can range between 11 and 18 years old, while professional dancers can range between 18 and 35 years old. The average age of retirement is 30 years old, but dance medicine has increased this up to 35 years old. Dancers are typically defined as overachievers and perfectionists, which can turn into an obsession. Beginning at a young age, dancers are exposed to pressures that predispose them to psychological stressors. These pressures come from others, such as teachers, choreographers, and directors, and from themselves. Pressures include being constantly criticized and critical of themselves, demand from others and themselves to master their art, and are told and expected to push through their pain. These pressures can lead to lack of sleep, poor eating habits, and increased fatigue. A survey published in Dance Magazine found that 40% of dancers reported having performance anxiety. Another study that used the Symptom Checklist 90, a highly validated screening tool for psychopathological symptoms, was given to performing artists who were receiving psychological therapy. From that study, they found that dancers had a higher clinical distress and depression than other psychiatric patients. Socially, dancers are with other dancers who are in a competitive environment and are working to achieve a higher social status within the dance company they are with. They have limited time to socialize outside the dance studio due to training, rehearsals, and performances. Dance companies put their focus on physical prevention and rehabilitation to prevent loss of rehearsal and performance due to injury, which can lead to loss of money. Dance companies are unable to or do not provide adequate mental health therapy or training to the dancers they employ. Negative stress and injuries have been linked to low social support within the performing arts dance community. Within a year, dancers experience a higher percentage of injuries, between 50 and 97%, and a longer recovery time is associated with negative life stressors. Fear of loss of status, role, or opportunity due to injury can lead to negative stress and unhealthy coping. A study on 46 ballet dancers found that they could predict 61% of injuries by the ballet dancer's anxiety level, worry, and loss of focus. The same study suggested that dancing more than 5 hours per day increases the risk of injury. Researchers have found that dancers between the ages of 13 and 18 have the highest level of injuries. After being injured, dancers can experience stress, paranoia, psychological distress, and disordered eating. Dancers work within a competitive environment, which is not conducive to develop a positive mental health. The competitive training environment for young dancers predisposes them to psychological distress. In a dance school, it is expected that only 5% of graduates will get a job as a professional dancer. The competitive nature of dancers can foster an unhealthy psyche, which can lead to overtraining, abnormal eating habits, body dysmorphia, and low self-esteem. Given the competitiveness of dancers, injury becomes their number one fear. Stressors imposed on the dancer increases the likelihood of getting injured. These stressors include the pressures to maintain physical dedication and to push through pain, a high expectation from self and others, job instability, and rigorous training schedules, as well as work and school conflicts and poor coping habits. Once injured, a dancer can lose their identity and self-worth. Dance medicine mainly focuses on the physical aspects of dance and treats the physical complaints. The healthcare system does not support or protect performing artists, giving them limited resources to seek help. Multiple reports of dancers' injuries go unreported due to misunderstanding between physicians and dancers. Dancers reported fearing they would be told to stop dancing. Most dancers do not have their own health insurance. If they do, it is through their spouse or parents. Once provided with health insurance by dance companies, they still may not cover mental health services. Harknick's Center for Dance Injuries, a prestigious dance physical therapy clinic in New York City, states that at least 50% of their patients do not have insurance or have high deductibles. This diagram shows how anxiety can be the primary cause for many dancers' problems. Such reasons include substance use, depression, eating disorder, performance anxiety, injury, burnout or overtraining, auditions, body dysmorphia, finances such as poverty, and career transition. These can all be contributed to anxiety and lead to another disorder. For example, auditions can cause anxiety, which can lead to eating disorders or depression. Another example could be when a dancer has an injury causing anxiety and developed depression and starts to use substances to decrease their anxiety and depression. Each dancer has their own road to anxiety, but finding the cause can help us better understand how to help dancers. One recommendation that I propose to help benefit performing artists get the help they need is to develop a first step program with a list of references of therapists who have worked with dancers and introduce a psychoeducational model into dance schools. Some current examples include a list of references of physicians, chiropractors, and dentists on the Performing Arts Medicine Association website. This website does not include mental health professionals. Additionally, Dr. Linda Hamilton, a psychologist who was a dancer and has worked with dancers for 19 years at the Alvin Ailey School in New York City, has successfully taught dancers how to cope with stress, nutrition, injury prevention, and stress management. To do this, I can partner with major organizations such as Chicago Dance United, Actors Fund, and Howard Brown Health to create a portal where a dancer can find referrals to a therapist and provide information on sliding scale cost and financial assistance. I can reach out to psychologists who have worked with dancers to see if they can dedicate 10% of their caseload to the performing arts community who cannot afford treatment and tap into local resources and funding to help cover the cost. Furthermore, dance schools can hire a psychologist who can run a psychoeducational program in their school. This program is based on the psychoeducational model. It is defined as facilitating self-development to be used with pre-professional dancers as a means of heading off the problems they might otherwise face later on in their career. This program is broken into two characters: the facilitator, and the pre-professional dancer. The facilitator is the psychologist who sees the dancers as a whole person and provides appropriate tools and techniques with good communication skills and develops mutual respect, acceptance, positive regard, empathy, and trust. The pre-professional is the dancer or dancers who are struggling with self-development. There are 3 stages within the psychoeducational model. The first stage is the initiation stage, where the facilitator creates a trusting and safe space to encourage innovation and creative ideas, accountability, and transparency. The second stage is the cultivation stage, where the pre-professional dancer is guided towards enhancing self-awareness. To accomplish this, they discover their own self-identity through actions, attitudes, emotions, and experiences. This leads the pre-professional dancer to self-assessment and confidence in their capabilities, values, and goals. In addition, they will cultivate personal potential, individuality, and inner self, and develop skills that promote self-responsibility through self-organization and ownership. Finally, in the third stage, the implementation stage, dancers have now developed their strategies for problem solving, and they can now take responsibility for change and develop inner growth. My second recommendation is to provide a mental health counselor affiliated with dance schools but is located off-site. A psychologist found that they had a more significant number of referrals when they were not in the school. To accomplish this, I can reach out to volunteers within the psychiatric community, apply for grants, and fundraise to help cover the cost. The dancers should be given the counselor's information. The psychologist should train dance teachers to recognize the signs and symptoms that indicate a mental health issue and refer them to the school's psychologist. And the provider should introduce themselves at the beginning of the year and make periodic check-ins so the dancers can become more comfortable with them. They should also be provided free dance class so dancers can see they understand their art form. My last recommendation is that when dancers go in for dance injury screens, physical therapists and athletic trainers should provide them with the brief symptom inventory, or BIS, to help identify psychological distress and help identify at-risk patients. To do this, the physical therapists and athletic trainers would need to be willing to screen the dancer using the BSI and be comfortable communicating the referral if the dancer is in need. Similar to athletes who need help, help usually comes from others who can provide a bridge. The limitation in my research is that most of the data collected was done with self-reporting surveys, which are already inherently biased towards a better self-image. Other limitations include the affordability and limited availability of dancers and psychologists. When a dancer is brought into a psychologist, the psychologist is usually doing crisis management. This can be prevented if we apply any of my suggestions and that we begin to recognize our limitations as performers and artists. Providing an online space so people can share their experiences with their own mental health journey can also help early prevention. Lastly, the psychoeducational model has not been tested in the field, but provides us with a starting point to develop and grow a program that will help all performing artists. This is the end of my presentation, but my goal is to expand and continue this work. please contact me at asuhad2@uic.edu for any questions, comments, or suggestions. Thank you.